Think about it. When you picture serious medical care, a hospital room probably comes to mind first.
Standard image.
But a fascinating shift is happening. Increasingly, hospital-level care is being delivered not just within those walls, but in people's own homes.
Yeah, might sound surprising at first.
It really might. But this growing model, known as hospital at home, is our focus today on the deep dive.
And we've got some really rich insights, fresh from the World Hospital at Home Congress.
Exactly. Our goal is to really understand what makes this approach to acute care at home safe, effective, and, a genuine alternative to traditional hospitalization.
It's about getting practical beyond just the idea.
Right. What does it actually look like?
And what's truly compelling about the discussions at this Congress is the depth and breadth of the knowledge being shared.
It wasn't just surface level.
Not at all. We're not just talking about the theory. We're diving into the fundamental standards for nurses in this unique space, innovative ways to deliver treatments like IV fluids.
Things you might not think are possible at home.
Exactly. Even managing complex illnesses like infective endocarditis and how rapid response systems are being adapted. Plus, we're seeing solid data emerge on patient outcomes.
So it's not just about moving services around.
No, it's a fundamental reevaluation, really, of how acute care is delivered.
Okay, let's start there then, at the foundation, the nursing care. How do you ensure really high-quality nursing when the hospital is someone's living room?
Well, that's a huge question, and there's significant work underway internationally to define exactly that.
I saw the International Home Care Nurses Organization, IHCNO, was involved.
That's right, IHCNO. They've been collaborating with the American Nurses Association, the ANA, to establish global standards for this specialty.
Because it is a specialty, right? Not just hospital nursing, but somewhere else.
Precisely. That's the core premise. Home-based care isn't just a simple relocation. It demands a specific set of skills and knowledge.
And IHCNO did a big study on this.
They did a really comprehensive 2-year study. They gathered input from professionals in 39 countries across all WHO regions.
Oh, that's broad.
It is. And that global perspective really emphasizes that even though healthcare systems vary wildly, the core elements of excellent home-based nursing have a lot in common.
What are some of those unique aspects they identified?
Well, a key one is the nurse's autonomy. In a home setting, the nurse is often operating with a high degree of independence.
That might be the only healthcare pro there at that moment.
Exactly. Making critical decisions, assessing the patient, sure, but also the home environment itself. Is it safe? What resources are available? How do we involve the family caregivers?
And the dynamic shifts too, doesn't it? It's the patient's home turf.
Completely. The patient has considerably more authority, more agency, and the focus really shifts towards empowering them towards self-management.
So education becomes key.
Absolutely crucial. Home-based nurses need to be exceptional educators, making sure patients and families have the knowledge and resources they need when the team isn't physically there.
And working closely with those caregivers.
Essential. They become extensions of the care team. And we're also seeing a greater emphasis on nursing leadership within these home-based interprofessional teams.
So this IHCNO study, what exactly did they look at? Scope, standards?
They focused on 3 critical areas. Scope of practice, basically, what nurses are allowed to do legally.
Okay.
Standards, that these are broader statements about what quality nursing should achieve, kind of aspirational.
Got it.
And then competencies, the specific measurable knowledge, skills, and behaviors needed to meet those standards.
How did they figure these out?
They started by reviewing existing research, looking for frameworks already out there. Then they conducted 4 online surveys to get that international perspective on scope, standards, and competencies.
And they landed on 4 main domains: practice, education.
Right. Practice, education, scholarly inquiry, and leadership and advocacy.
Can you give an example from, say, the practice domain?
Sure. Within practice, there are 11 standards. Things like basing practice on core values, ethical and legal practice, providing diverse services, ensuring quality, person-centered care, kind of the bedrock stuff.
Makes sense.
And education, 2 standards there, focusing on lifelong learning for the nurse and the importance of mentoring others.
Scholarly inquiry.
Also 2 standards, using evidence-based practice, obviously crucial, and participating in research.
And finally, leadership and advocacy.
4 standards there. Things like demonstrating leadership, advocating for patients and for healthy work environments, staying informed on healthcare trends, and, importantly, taking responsibility for their own professional well-being.
And these aren't just abstract ideas, right? There are specific competencies tied to them.
Exactly. So under practice, a competency might be implementing robust infection prevention in the home, which is different than in a hospital.
Sure, different challenges.
Or under leadership and advocacy, it might be evaluating your own leadership skills and actively working to improve them within the team.
So these standards are meant to be practical tools.
Yes, definitely. They can guide education programs, inform curricula, help develop policies, even serve as advocacy tools for the profession.
And you mentioned they align with UN goals.
Yeah, it's interesting. They connect with the Sustainable Development Goals on good health and well-being and reducing inequalities, recognizing how home-based care can potentially expand access.
And this work is ongoing with the ANA.
That's right. They're collaborating to finalize this foundational scope and standards document. Really important work.
Okay, so that sets the stage for high-quality nursing. But what about some of the trickier medical interventions? Let's take 5E fluids.
Yes.
You can't easily replicate a 24-hour continuous drip in someone's living room, can you? Multiple pumps, mobility issues.
That's precisely the challenge the team at NUHS at home in Singapore tackled. Continuous infusions are standard hospital practice, but yeah, logistically very difficult at home.
So what was their workaround?
Their innovative solution was using fluid boluses. So instead of a slow drip, they might give, say, 1 liter over 60 minutes, maybe twice a day, to hit a 2-liter daily target.
Right. My first thought, though, is fluid overload. Isn't that a risk, giving it faster?
That was the immediate concern, definitely. But when they dug into the literature and guidelines, like the UK's NICE guidelines, they found the focus was often on the total dose needed per day, not necessarily rigidly fixed on the infusion rate itself.
Interesting. So they studied their own patients receiving these boluses.
They did. They audited 166 patients in their hospital at home program who got fluid boluses. They were careful to exclude anyone who was clinically unstable to start with.
How did they track fluid overload? What were they looking for?
They used a few indicators.
Yeah.
A clinical diagnosis by the doctor, signs on a chest x-ray, or if the patient needed diuretics water pills to get rid of excess fluid.
Good.
And they specifically identified a subgroup of 32 patients they felt were at higher risk to begin with. Things like heart failure, chronic kidney disease, being very frail, or having a very low body weight. These folks tended to be older, average age 78, with more health issues.
Compared to the others.
Right. The not at risk group had an average age of 42, fewer comorbidities. The reasons for needing fluids also differed a bit.
How so?
The higher risk group often needed fluids for simple things like dehydration or low volume. The lower risk group more often things like rhabdomyolysis or dengue fever, which is common in Singapore.
Okay, the big question. Did the bolus approach cause problems? What was the overload rate?
The results were actually pretty reassuring. Overall, the rate of diagnosed fluid overload was really low, just 1% across all 166 patients.
Only 1%.
Yeah. Even in that higher risk group, it was only 6%, which amounted to just 2 people, and 0 cases in the not at risk group.
That's quite low.
It is. And they also noted that the total fluid volumes given were often actually lower than what guidelines might suggest.
Can you tell us about those 2 cases where overload did happen?
Sure. One was a 91-year-old woman who, looking back, probably already had some overload before getting a 500 milliliter bolus. She developed shortness of breath and was diagnosed with heart failure.
Okay. And the other?
The other was a 68-year-old woman. She developed a fever and some breathing changes after a 500 milliliter bolus. Her x-ray suggested possible overload, but ultimately her symptoms were put down to pneumonia and she didn't actually need any diuretics.
So the takeaway from their audit?
The conclusion was that fluid boluses seem to be a safe and, importantly, a much more logistically practical alternative to continuous IV fluids in the hospital at home setting. A really smart adaptation.
That really is insightful. Okay, let's push the complexity boundary further. What about treating something like infective endocarditis at home? That's a serious heart infection, usually needs weeks of IV antibiotics in hospital.
Absolutely, it's a major condition. But a team at one hospital at home unit decided to look into this. They specifically wanted to see how well existing guidelines for outpatient treatment of endocarditis would apply in their home-based care model.
Which guidelines were they looking at?
They focused on the OPAT GAMES criteria, which were developed in Spain. OPAT stands for Outpatient Parenteral Antibiotic Therapy.
Okay.
These criteria are basically a checklist to identify endocarditis patients who might be suitable for getting their IV antibiotics as outpatients, with specific reasons to exclude someone like severe liver disease, brain clots, big abscesses, things like that.
And had these criteria been validated before?
Yes, initial studies suggested they were pretty good for selecting patients for traditional outpatient antibiotic setups.
But, as was emphasized at the Congress, hospital at home is more than just getting an infusion at home, isn't it?
Exactly. It's a much more comprehensive model. So this team compared outcomes for patients within their hospital at home program. They looked at 27 patients who met the OPAC Games criteria versus 17 who did not.
And how do these patients look generally?
Average age was around 63. Both groups had a fair bit of severe valve disease, previous endocarditis, mostly native valve infections, often the aortic valve. Staph and strep were the common bugs. Pretty typical endocarditis picture.
Okay, so what happened when they compared outcomes?
Well, here's where it gets interesting. They actually saw a trend. It was statistically significant towards a longer median length of stay in hospital at home for the group who met the OPAT Games criteria.
Longer stay for the ones supposedly suitable for outpatient. That's backward, isn't it?
It is counterintuitive, and maybe even more importantly, they found no significant differences between the groups when it came to major complications, like developing heart failure, having brain embolisms, surgical site infections, needing to be escalated back to the main hospital, or overall mortality.
No difference in death rates.
Nope. Overall mortality was about 9.5%, which sadly isn't uncommon with severe endocarditis, but it was similar in both groups, 2 deaths in each group after they needed escalation back to the acute hospital.
So what's the main message from this study then?
The key takeaway seems to be that while OPAC Games might work for standard outpatient settings, they might not be the best predictor of outcomes, specifically for endocarditis patients managed under a comprehensive hospital at home model.
The criteria don't quite fit the context.
That's what they're suggesting. The criteria might not fully capture the nuances, the resources, the intensity of care possible in hospital at home. Their recommendation is basically, we probably need specific criteria tailored for hospital at home endocarditis treatment.
What else did they recommend?
Things like implementing really robust monitoring for these patients at home, strengthening the links and communication with traditional hospitals, and of course doing larger prospective studies to confirm these findings. It really underlines that you can't just copy-paste guidelines from one care setting to another.
Makes perfect sense. You need to tailor it. Okay, considering the whole ecosystem of care. Now let's shift gears slightly. How do patients actually get into these hospital at home programs, especially if they have an urgent need? I saw something about rapid response teams.
Yes, this is a really interesting development focused on preventing unnecessary trips to the emergency department and maybe even hospital admissions for patients with chronic, complex conditions.
How does that work?
Well, in Catalonia, Spain, they have chronic care programs that identify patients as either complex chronic patients, CCPs, or advanced chronic patients, ACPs. The idea is when one of these patients has a flare-up, instead of heading straight to the ED, a rapid response team can potentially go to their home, assess them there, and if it's safe and appropriate, admit them directly into the hospital at home program, bypassing the ED completely.
So bringing the hospital admission process essentially to the patient's doorstep.
Exactly. And they studied this. Researchers did a retrospective case control study. They compared patients admitted via this rapid response team, the cases with a matched group admitted via the traditional ED route, the controls.
How were they matched?
Carefully. Based on age, sex, the complexity score of their illness, and their history of previous hospital admissions using propensity scoring. They ended up with 208 patients in each group.
What kinds of conditions were these patients typically admitted for?
Common things like UTIs, worsening heart failure, respiratory infections. They did note respiratory infections were a bit more common in the ED group, and anemia was more frequent in the rapid response group, but generally similar reasons for admission.
Okay, and the outcomes. How did the rapid response admissions fare compared to the ED admissions?
The findings were really quite positive. No statistically significant difference in the average length of stay in hospital at home, around 10 or 11 days for both.
What about needing to go back to the main hospital?
The transfer rate back to the acute hospital was low and almost identical, around 5 or 6% in both groups.
And mortality during the hospital at home stay?
Also very low, and the same, just 1% in each group.
That sounds really good. Suggests the rapid response route is just as safe for these selected patients.
It certainly points that way. Now, they did see high readmission rates at 12 months, around 55%, but that likely reflects the severe chronic nature of these patients' illnesses. Importantly, there was no significant difference between the groups.
And long-term mortality.
Also high, sadly, but again, no significant difference between the groups at 12 months post-discharge.
So the conclusion.
The researchers concluded that for these carefully chosen patients, the rapid response team admission wasn't inferior to the ED route. And it suggests that getting primary care involved early to identify these patients could significantly cut down on ED visits.
Makes sense. Are they studying this further?
Yes, they mentioned an ongoing, larger prospective study called Health Multicenter to look more deeply into the long-term impact.
Good. It's about getting the right care, right place, right time. Okay, so we've covered nursing standards, adapting treatments, different access routes. What about the big picture, the overall impact? Are we seeing good real-world outcomes from hospital at home?
Yeah, and this is where some compelling data from Canada comes in, specifically from Island Health in British Columbia.
Tell me about that.
Their at-home research program has taken a very patient-focused approach, and they've really integrated their findings into clinical decision-making. The program started back in late 2020 and has already cared for over 3,100 patients.
That's quite a number already.
It is. And importantly, their rate of needing to transfer patients back to the traditional hospital has consistently stayed within their target of 6 to 8%.
So they're keeping most patients safely at home. Did they compare outcomes more formally?
They did, using a large Canadian health database, CIHI. They did a rigorous matched cohort analysis looking at over 26,000 records.
Wow.
They managed to match 11,129 of their hospital-at-home patients with similar patients who got traditional hospital care, matched on age, gender, comorbidities.
Were the groups truly similar?
Seems so. Average age in the mid-70s, similar gender split, same top 3 diagnoses: heart failure, COPD, UTI. Even similar initial lengths of stay and lab tests per day looked comparable.
Okay, so the comparison is pretty solid. What were the key outcome differences?
The results were quite striking, actually. The hospital-at-home group had significantly lower rates of hospital harm.
What does that include?
Things like hospital-acquired infections, medication errors, pressure sores, that kind of thing. It was 5% in the home group versus nearly 8% in the traditional hospital group.
That's a notable difference. What else?
Lower rates of hospital-acquired delirium, less than 1% versus 2%, and significantly lower 30-day mortality rates.
Oh, much lower.
1% in the hospital-at-home group versus 2% in the traditional hospital group. Their analysis suggested a number needed to treat of 56, meaning treating 56 patients at home instead of hospital, potentially prevented 1 death within 30 days.
That's powerful. Any other benefits?
Yes, fewer alternate level of care days, those days spent waiting in hospital for discharge arrangements, less than 0.5% versus nearly 9%, and fewer patients discharged to nursing homes from the hospital-at-home group.
And readmissions?
Also lower. 30-day readmission rate was 9% for the home group, compared to 13% for the traditional hospital group.
That's a really strong case for the model's effectiveness. Were there any downsides or areas where the hospital performed better?
They did report a higher rate of falls in the hospital-at-home group. It was about 20 per 1,000 discharges versus about 8 in the hospital.
Why might that be?
The researchers had a couple of theories. One, patients might just be more mobile and active in their own familiar environment compared to being more restricted in a hospital bed, which ironically might also help prevent deconditioning.
Okay, more movement, more chance to fall, maybe.
Possibly. And also, they suggested that falls occurring at home might just be documented more diligently by the home care team. Every stumble gets noted, perhaps.
Right, documentation differences.
Yeah.
Anything else?
They did note a slightly longer average length of stay in hospital at home compared to the estimated length of stay for those conditions in a traditional hospital setting, based on CIHI data. But overall, the conclusion was that hospital at home appears safe and effective in their Canadian context, with outcomes that are comparable or even better in several key areas. They've even developed a prediction tool to help identify patients at higher risk of needing to come back to hospital.
Based on their own data?
Yeah, based on over 960 cases. Interestingly, they found patients with end-stage liver failure had extremely high readmission rates, so they actually excluded them from the program based on that data. Real-world learning.
It sounds like, while there's great progress, there are still ongoing questions and learning happening. The Congress had a Q&A session, right? Did anything insightful come up there?
Absolutely. Some really practical points. One was about those international nursing standards we talked about first. How applicable are they really across different systems?
Good question.
And the answer was basically they're designed to be pretty fundamental and broadly relevant because of that diverse international input. The idea is for organizations to use them as a benchmark, to compare their own policies and education against them.
Okay. What else?
Someone asked about patient satisfaction with the fluid boluses in Singapore. They didn't have specific data just on the fluids, but overall patient feedback for the NUHS at Home program was overwhelmingly positive. Patients generally recommend it.
What about the need for more research, like randomized controlled trials, RCTs?
Yeah, that always comes up. RCTs are the gold standard, right? But they can be tricky to implement in hospital at home. Patient participation is voluntary, needs consent.
Logistical hurdles.
Right. The Canadian team made a good point that real-world data, like theirs, is incredibly valuable for understanding how these programs actually perform in practice, especially when you're rolling them out in new settings.
Makes sense. Was deconditioning discussed? Losing fitness during a stay?
It was touched upon. Direct comparison is hard, but the Canadian team includes questions about mobility in their patient experience evaluations. And on nursing development, are there specific milestones for hospital-at-home nurses?
Beyond entry level.
Exactly. The current competencies are more for entry-level home care. Developing advanced milestones specifically for the acute hospital-at-home nurse is seen as important future work.
And it's not just nurses, right? What about the doctor's role?
Definitely not just nurses. Both Singapore and Canada stress the multidisciplinary team. Doctors, often internists or specialists, lead rounds, sometimes virtually, sometimes in person, stay in close contact. But they really emphasize the vital role of nurses, pharmacists, therapists, social workers. It's a true team effort.
Team effort in the home.
Exactly. And the Q&A also circled back to the key differences between hospital nursing and home-based nursing. The details are really in those specific competencies.
And falls prevention came up again.
It did. They talked about using standardized risk scales, like the Morse scale, getting OT and PT involved for home assessment, sometimes using fall detection tech.
And the higher reported rate at home.
Again, possibly due to more mobility, but also maybe more thorough documentation by the home team. The types of risks are different too. Rugs, stairs at home versus a flat hospital floor, but that increased mobility might also help recovery.
Interesting trade-off, potentially. What about the rapid response team in Catalonia? How does primary care fit in?
Crucial role. The GP is often the one identifying the complex patient having a flare-up who might avoid the ED. The GP calls the hospital-at-home team and nurse triages, and then the response team, usually a doctor and a nurse, goes out for that comprehensive assessment at home.
Got it. And finally, what about the role of patients and caregivers themselves in this model?
Huge emphasis on this. They're seen as essential partners, often the first ones to notice subtle changes because they know the patient's baseline.
An early warning system.
Exactly. Good communication channels allow caregivers to flag concerns directly to the team. This involvement is seen as key for both safety and patient satisfaction.
So pulling it all together, it really feels like hospital at home isn't just a niche idea anymore. It's a really dynamic and rapidly evolving field.
Absolutely. We've seen the groundwork being laid with nursing standards, clever adaptations like the fluid boluses, new access models like rapid response.
And the outcomes data, particularly from Canada, is looking pretty compelling.
It really is. It strongly suggests this isn't just about convenience or shifting costs. It seems to be about providing genuinely high-quality, patient-centered care.
Right, in a setting that, for many, is just more comfortable, more familiar, maybe even better for healing. And clearly, there's a real commitment to ongoing research and improvement.
Which brings us to a final thought for you, the listener. How might this growing integration of acute care into the home fundamentally reshape our whole understanding of hospitals? What are hospitals for if complex care can happen elsewhere?
And maybe even more profoundly, what role will patients and their families increasingly play in managing acute illness as this transformation continues?
Definitely something to think about. It's a space worth watching very closely. We'd encourage you to check out the research referenced if you're interested, and keep following the advancements in this really exciting field.